with you. You are all aware about it. I left it for you here to read, and if I will share with you the presentation, which I will be happy to do that. If you email me your email, I will be happy to share with you the PDF of the presentation. It's for you for general information. Risk factors. Risk factors are important because that's how we decide this patient is a high-risk patient for preterm birth or not. And risk factors are historical, infection, and cervical and uterine. Those are the major risk factors that we would discuss. Historical, previous preterm births, this is probably the most significant. And we know that the risk increase with how far in gestation preterm births happen and how many of them. And then risk factor, other risk factors which are probably not as important, such as medical and or obstetrical complications, extremes of age, poor socioeconomic or rate of prenatal care. Let me just adjust my pointer for a second so you can see it better. Thank you. All right. So these are the historical factors. Now, infection. This is your worst enemy here, as you're going to learn in a few minutes. There is a clinical, there is first intrauterine infection, clinical, which all familiar with, such as chorioamnionitis. Subclinical, which is the one that really causes the preterm labor, you don't see, but it's present if you check the pathology of the uterus, which is the infection at the level of the choriodecidual versus the intraamniotic infection itself. Urinary tract infections, you're familiar with pyelonephritis or asymptomatic bacteriuria, cervical or vaginal colonization, such as bacterial vaginosis. Now, uterine and cervical, that's important also. Uterine malformation, especially the ones who deal with infertility and IVF, you know, uterine malformation or large fibroids, cervical insufficiency or incompetence, which way you want to call it. And that's for people who have historical cervical incompetence or have scarring, such as cervical conization, leap, cervical laceration, multiple abortions, especially second trimester with DNE, or overdistension, as you are all aware, especially people who are doing IVF, multiple gestation, polyhydramnios, and fibroid uterus. Intrauterine infection. Why infection happens? Well, normally the vagina has a large pool of what is non-pathogenic organization, okay? This is the normal flora of the vagina. They inhabit the vagina, but they are not causing any harm unless they cross the natural barrier to the choriodecidual space. Please bear in mind this choriodecidual space, because this is here is the most important thing. So they cross the barrier for whatever reason, we're gonna learn about it in a few minutes, and go to the choriodecidual space and into the amniotic cavity into extreme cases. Most common organism, very important, ureaplasma urethriticum, 80% of the genital flora. When it's in the genital flora, it doesn't cause problem, but when it gets into the uterus, it could be a major problem. Mycoplasma, and less common, other bacteria, which are mostly anaerobes. Okay. So essentially what we are talking about here, we have a pathological process that results in the activation of a physiological one, which is the process of labor and delivery. But that's physiological when it's on the proper time. Pathological when it happens in earlier than that or in unusual circumstances. That would result into contraction, cervical dilatation, with or without ruptured membrane, and eventually would end up with premature delivery. So Now, what triggers this process? Infection is your worst enemy, as I indicated before, especially before it gets into the amniotic cavity at the level of the choriodecidual space. And then you have decidual hemorrhage, or which is abruption in this case, or vascular, such as problem with failure of modulization of spiral artery, such as preeclampsia, or pathological uterine distension. So we have here pathology. All these are hypotheses, theories. We're not sure that this is work or not, but with best of our knowledge, it does work to produce preterm delivery. Bottom line is that, unfortunately, we do not. The sad news here, is that more than 90% of preterm births happen in singleton pregnancies, not in twins or multiples, without known risk factors. So you have to have your ears, your eyes open, and you have to always think about preterm births. I believe I gave a lecture about 2 years ago, live in Cairo, and we talked about preeclampsia, and I also told you the same thing. You have to always think preeclampsia. Now, remember a few minutes ago, I told you that we do not essentially like to make too much distinction between preterm labor, premature rupture of membrane, or cervical incompetence, because they're all one continuum. And here what it is, this is like which one came first, the hen or the egg. So you can have preterm birth start, can cause you premature rupture of membrane, can cause you preterm labor, cervical insufficiency, can cause you both. So it is a continuum. That's why we like to address the whole problem together, because as you're going to see a little bit later in the lecture, I will be talking about incompetent cervix. And you're going to say, hey, this guy is supposed to talk about preterm labor. Why is he talking about cervical incompetence? No, it is part of it. It's not anymore cervical incompetence, just only that would that will result into a second trimester miscarriage. No, it is a major issue in preterm. Okay. Now, preterm delivery, and that's why I said clinician priority. Preventing preterm labor before it takes place is probably, in my opinion, and the opinion of many other people who are practicing in the field of maternal fetal medicine, is the mainstay. Treatment, because treatment is unsuccessful in majority of the cases. I'm going to revert to my native language, Arabic, in a second. Al-wuqaya khayrun min al-ilaj. Okay. Preterm birth prevention, risk factors. We said that there is historical factor, and then after that we talk about infection, bleeding, cervical uterine, all this. So, previous preterm births, the correlation is strong. Number, sequence, and gestation age when it happened. Cervical length, when it is short cervix, especially between 18 and 24 weeks, is a very strong correlation and consistent, especially if associated with history of preterm birth. So really, your mainstay is these two items here: history of preterm birth and short cervical length, and that's usually the subject of all or most of the research that happened in that field and continue to happen. So one that I wrote in smaller fonts, which is demographic and poor OB, yeah, okay, can help a little bit, but not too much. Now, prior preterm birth or history of preterm birth. Generally, if you have one prior preterm birth, the risk is 25%. Increase if you have two or more, about 42 can reach 250 or more. When it happens, if it happens late, the risk is not that high. But if it's happened less than 32 weeks, the risk is almost 60%. Short cervix. The strongest correlation here, because that's now we have objective data. When we talk about historical data like history of preterm birth, this could be subjective to memory, subjective to where pregnancy took place, or other cofactors. Cervical length, now, this is something objective. And I hope that when I measure a cervix as 20 millimeter, other people, when they measure it, it would be somewhere between 18 and 22. So the observer variation will not going to be too high. And that usually happens if you know what you are doing. So if we have a cervix less than 25 millimeter, 2.5 centimeter, that corresponds to about the 10th percentile. The preterm birth risk factor is 25 to 30%. It doubles to 50% if it is less than 15 millimeter, and that represents the third percentile. That's very important. Those two numbers are very important. You have to remember them by heart. It is even stronger and more consistent if it is associated with history of preterm birth. So previous preterm birth, cervical length together, very important. So if you have a history of preterm birth, but the cervix is greater than 35 millimeter, really your preterm birth risk is less than 10%, which is like anybody in the normal population. Previous preterm birth and cervical length less than 25 millimeter, the preterm birth risk factor jumped to 35%, 1/3 of the cases. So you have to have a good history. You have to learn from the patient the circumstances which happened in the previous pregnancy or previous pregnancies. And if you can, and I'm very serious about that, if you can obtain records, that would be ideal for you. Short cervix can cause by many things, okay? You can have cervical trauma, previous surgery, somebody had a difficult delivery, especially instrumental delivery, intraamniotic inflammation or infection, previous preterm birth, congenital short cervix, such as in DES, luckily we don't see them anymore, or people with Ehlers-Danlos syndrome, and suspension of progesterone action. These are all kind of like, possibilities why you can have a short cervix. Cervical evaluation. It is advisable between 16 and 24%. If you have twins, maybe you can start earlier. Indication, prior preterm birth, absolutely. Anybody with prior preterm birth, you should start to evaluate their cervix by 16 weeks. History of cervical surgery, conization, LEAP, cervical dysplasia, somebody who has repeated abnormal cervical dysplasia. History of trauma, okay, multiple abortions, second trimester abortion, very, very serious of this thing. You cannot take it just lightly, say, hey, that's nothing, that happens a lot. Previous cerclage, Mullerian malformation, as we discussed before, bicornuate uterus, didelphic uterus, septate uterus. History of ART, and I'm going to stop here. And you're going to tell me, well, somebody has an ART. Why would you consider they are at risk if they didn't have any of the other risk factors before? No, I can tell you, based on experience and based on statistics, yes, ART, IVF, ICSI, all this carries a risk of preterm labor. We don't know why. It could be historical, it could be something related to the development, it could be somebody missed the presence of a small uterine anomaly, it could be that they underwent a lot of procedure before, such as hysteroscopy and DNCs and endometrial biopsies. So in addition, that this pregnancy is very expensive. It costs them an arm and a leg. In the US, the average cost of an IVF pregnancy is in the excess of $30,000. I'm sure it's the same everywhere else, relative. So, and the last item here, which is the elephant in the room, is universal screening with 20 weeks anomaly scan. We all do anomaly scan around 20 weeks, could be a couple of weeks early, a couple of weeks later. Patient is there, checks the cervix. You will gonna pick up at least 5% of cases where you're gonna have cervical insufficiency in people who have no risk factor, even in progress. This is just only for you. I'm not gonna over it. This is how the steps of the proper cervical length measurements. And I told you before, that's if we all speak the same language, if we all do the same technique, then it doesn't matter who does the cervical length. So in this case, observer variation will be much less. Cervical length, we all agree that it should be done with vaginal ultrasound. You should have a good picture. You can see the whole cervix, you can see the internal os, you can see what the external os is, you can see the amniotic fluid. Bladder should be empty. No too much pressure of the probe with the probe on the cervix. Now, these are the cervical changes, the temporal or by time, what happens. This is here your normal cervix. It looks like a T shape. When it starts to open at the internal os, when the pregnancy becomes a little bit heavier, it's gonna turn to be a Y. More pressure, it's gonna turn to be a V. And more pressure than when there is bulge of the membrane through the external os, it's gonna be like a U. T, Y, V, U. Definitely, you do not want to get to the U stage. Preferably if you don't get to the V stage. So your intervention should start from here when it gets to be a Y. Okay. How progesterone reduced preterm birth? That's a lot of theory. I don't think it is, it's a time to talk about it. This is a whole lecture by itself. But hypothesis is that there is effect on the cervix, uterus and myometrium, decidua, placenta and fetal membranes, and endocrine. Bottom line, it works. Now, progesterone, vaginal versus parenteral, or 17-hydroxyprogesterone caproate. For a while in the US, 17-alpha-hydroxyprogesterone caproate was the standard of care, and anybody who have a history of preterm birth would be a candidate. It's a very expensive medication, and there was a lot of reluctancy for several reasons to use it. Number one, safety, not natural. The caproate is given to increase the half-life. There were studies, even in Paul Mees study, the original one, which was NIH-funded study. There was increased risk of miscarriage and fetal deaths. Not effective with twins, not effective if short cervix. There was, in addition to that, flaws in the original study by Mees. There was over-representation of preterm births in the placebo group because this was a double-blinded RCT, where 55%, this is not right. And at that time, there was a rush from the FDA to approve it. So it was approved under something called subpart H of the code. Don't have to worry about it. So it's more like I said, emergency type of approval. Essentially, this reminds us of the approval of the COVID vaccination. The placebo was castor oil, which stimulates contraction. So these are big flaws in the original study by Paul Mees. Now, the prolonged study, which is a more recent study, I believe this was in 2019 or 2020, it was published. It was an RCT double-blinded, placebo-controlled, the same as the original study by Paul Mies. History of preterm births, singleton, they either received weekly 17-hydroxyprogesterone caproate or placebo. Outcome, preterm birth less than 35 weeks. So it was essentially a mirror image of the Mies study. 11% versus 11.5%. That's nothing. Conclusion, 17-hydroxyprogesterone does not reduce recurrent preterm births, and it has been withdrawn. Preterm birth twins. So let me go back to this slide. So that means that we have not eliminated progesterone, but now we are using more activation progesterone. Preterm birth prevention, twins. Twins births in the US and all over the world is probably like around maybe 3 to 4% of live births. 9-time singleton pregnancies, limited success with traditional measures such as bed rest, tocolysis, cerclage, pessary, and progesterone. So what to do? Especially that the number of twins keep on increasing because of the increasing in the number of ART. Progesterone and twins. Yes, it works. This is a study, combined study, where by two major players, Roberto Romero from the US and Kypros Nicolaides from the UK. It's a meta-analysis, and there was a decrease in preterm births, okay? And also decrease in neonatal morbidity and mortality. So progesterone in twins and singleton works. Now, this is more or less, it's going back again to the 17-hydroxyprogesterone. It's ineffective, may increase risk of preterm labor, may increase neonatal morbidity and mortality, and does not work in twins. Some studies came saying that, hey, progesterone and cerclage are the same. Well, I'm not sure that I agree with that. I think that each one of them has its own indication, but this, the only reason I'm showing you this, because it's emphasized that progesterone works, especially vaginal progesterone. Now, cerclage. You all aware about cervical cerclage. McDonald procedure, which what it is, it's a purse ring suture. That's the majority of the cerclage that are done. And the original Chirurg car, where you have to advance the bladder and put a suture around the cervix and tie it. This one, a little bit more complex, probably old people like myself are still doing it. Younger people, maybe they have not seen it quite often, but it still has its indication. So, can cerclage prevent preterm birth or not? Does it work or it doesn't not work? This is a very lousy slide, and I made it intentionally lousy to be very confusing, because I wanted to tell you that there are equal studies that shows that it works versus it doesn't work. So don't pay attention to this thing. Okay. This is one of the studies where they studied preterm births, history of preterm births between 17 and 34 weeks. Cervical length was done between 17 and 34 weeks every 1 to 2 weeks, from 16 to, sorry, this is going too far. History of preterm births, less than 34 weeks. Cervical length every 1 to 2 weeks from 16 to 24 weeks. Cervical less than 25 millimeter. They were randomized to cerclage versus no cerclage. No significant reduction in preterm births less than 35 weeks. Significant reduction in pre-viable births. Significant reduction in preterm births less than 35 weeks if you use a cervical length of less than 15 millimeter. So, in some opinions, that 15 millimeter is the time to go ahead and intervene and do a cerclage. Do we all agree about that? I don't think so. I think some of us, like myself, I take a little bit more conservative approach, and usually I use 25 millimeter. And you can argue saying, well, this is a good study, yes, but based on clinical experience, I rather do it when the cervix is a little bit long rather than waiting until the cervix becomes too short or there is bulging of membrane, because that can happen easy in 1 week. Okay, cerclage for twins, and I'm sure that you are all aware that was a subject of extreme controversy. For some time, we were told that you should not put cerclage for twins. And that was based on many studies. And this one of the meta-analysis that was done and showed that cerclage does not work in addition to the Raphael study. So they said that if anything, actually, cerclage does not work with twins. If anything, actually, it might even increase the risk of preterm birth. So the conclusion from the original study, cerclage does not work. This, unfortunately, has been addressed by major organizations such as the Royal College of OBGYN. You're probably all aware about that because most of you are British Associated trained. For us in the US, the American College of OBGYN also said you should not do cerclage for twins. So we, as maternal fetal medicine doctors, which deal with high-risk pregnancy, we were put in a really very tough situation. You have a major organization saying you should not do it, then you have a twins come to you, she had a history of IVF, she paid an arm and a leg, she had gone through all the suffer psychologically and emotionally and socially to do it, and now she's pregnant with twin, and now she's 18 weeks with the cervix dilated, and I'm gonna tell her, I'm sorry, I'm not going to be able to do the cerclage because the American College or the Royal College told me I cannot do it. I don't think anybody would then buy this argument. So that led that many people say, hold on a second, that cannot be true. And let's see if this really true or not, because you cannot just change the practice you are dealing with for years based on a few studies. So this was a retrospective court study. And there was twin cerclage versus expected management if cervical less than 25 millimeter. Primary outcome was preterm birth less than 35 millimeters. Yes, again, the 25 millimeter was not significant. However, there was a significant improvement if it's less than 15 millimeters. So if you don't like to use the 25, at least use the 15 millimeter. So conclusion, cerclage work in twins if cervical length is less than 15 millimeters. This was a retrospective study. Now, okay, this is a systemic review and meta-analysis. Twin cerclage if cervical length is 15 millimeter, or now this is good because this meta-analysis included also twins which by digital examination or speculum examination, the cervix was 10 millimeter or more dilated, 1 centimeter or more. Outcome was pregnancy prolongation about 7 weeks in the group that have the cerclage, decrease in preterm birth across the board at 34, 32, 28, and 24 weeks, and improved neonatal outcome. Conclusion, cerclage work when indicated in twins. Data are retrospective. One second here, let me stop here. I am not advocating that you do cerclage for every twins. Please, that's not my message. Cerclage in twins when indicated. Okay? This is now, okay, people who say, okay, fine, no, I don't like meta-analysis, I don't like retrospective court study, let's do a randomized clinical trial. Okay, well, here is one. This is Amanda Roman, that's from Dr. Bergelo's group in Thomas Jefferson University, one of the prominent places who studied preterm labor. twins, cerclage versus expectant management. Okay. Asymptomatic twins, cervix 20 millimeter dilatation with or without bulging of membrane. I intentionally ignored to tell you that this was based on clinical evaluation, not on ultrasound assessment. So here's somebody who you examine the cervix and it's approximately 2 centimeter dilatation. Some patients were 1, some patients were 3, but the average yield was 20 or 2 centimeter dilatation. Outcome, combination of cerclage, because these people, they underwent cerclage, they had antibiotics, and some of them received endomethacin. Interval diagnosis to delivery, average 8.3 weeks in cerclage, 2.9 weeks in controlled study. So the pregnancy prolonged at least 8 weeks. Decrease in preterm births across the board, 34, 32, 28, and 24 weeks. Perinatal mortality decreased by 77%. Conclusion, yes, cerclage work when clinically indicated. The same group now there is a RCT in progress where they are also examining the ultrasound indicated cerclage. All right, pessary, this funny thing here. Some studies came, pessary may work, it's nice, easy, cheap, why not using it? The reason to use it because it corrects the uterocervical angle, so the pressure we're gonna go to low uterine cervix versus low uterine segment versus cervix and prevent dilatation. Now, there are mixed results, can be used if no other option for past cerclage time. You have somebody who's now 26 weeks, you don't do cerclage past 24 weeks, cervix is dilated, she's not contracting too much, you need to give her something, maybe you can put a pessary in this case. Okay, what is this? Well, this is a U that you do not want to see. Sorry, here it is. What is this funny structure? Anybody can tell me? Okay, this is what we call it amniotic fluid sludge. Okay, these are dense aggregate of particulate matter in the amniotic fluid close to the internal os. This could be sometimes the vernix of the baby, could be sometimes blood, but in our situation here, I would worry big time about infection. Amniotic fluid sludge is an independent risk factor for preterm labor, premature rupture of membrane, and intraamniotic infection, and even chorioamnionitis. So, are there studies? Yes, from Romero's group. Amniotic fluid sludge increase risk of preterm birth 9 times at less than 28 weeks and 6 times at less than 32 weeks. So if you see it, this patient is a high risk, you have to observe her very closely. Amniotic fluid sludge and cervical length, which is very important. If cervical length is less than 25 millimeters, increase risk of preterm birth by 15 times at less than 28 weeks and 10 times less than 32 weeks. See here, you know, amniocentesis, 22% intraamniotic infection when sludge is seen. So this is a major concern for infection and a major concern for preterm birth. Okay? This is a study here where people who argue saying that, hey, does antibiotic works or not in preterm labor? Yes, if you have a painless cervical dilatation greater than 1 centimeter between 16 and 28 weeks, this was a study. I believe the study came from Korea. Amniocentesis confirmed intraamniotic infection. People who had an amniocentesis that confirmed intraamniotic infection, they received a triple antibiotic therapy. Cefotraxone, clarithromycin or azithromycin, which is azithromax, and metronidazole, which is a flash. Follow-up amniocentesis, treatment success was about 60%. Delivery at greater than 34 weeks, 18%. Negative infection or repeat amniocentesis is 41%. So that emphasizes the importance of infection. And the reason I put it to you, because it could be part of your protocol for treatment later. So what to do now? Okay. This is some guidelines here for prevention. You do people who are at risk historically or based on cervical or uterine factor or based on anything you want to consider, ART, twins, all this. You do vaginal ultrasound between 16 and 24 weeks. If twins, you might start a little bit earlier. If the risk was significant, maybe a little bit earlier. You can do it every 1 week, every 2 weeks. This is your decision. Cervical length cervical length between 16 and less than 25 millimeter, 16 to 25. No history of preterm birth, you may consider just giving vaginal progesterone. The protocol that we use is 200 milligram of progesterone every night until 36 weeks. History of preterm birth. Judgment call. Many of us would just go ahead and do a cerclage, and I'm one of them. Or, if you want to be a little bit less invasive, you can do vaginal progesterone and close observation. In this case, you have to see her like maybe every week or even less, more frequent than that. Further shortening, cerclage. So you have to be able to intervene on the right time to prevent further deterioration. I'm not saying that cerclage is a 100% benign procedure. No, it has its complication, but its major complication is failure of the procedure. And the procedure would fail if you wait too long. If you do a cerclage in a cervix with bulging membrane in the vagina, then your success is definitely less than 50%. Okay. Same protocol, cervical length now is less than 15 millimeter. History of preterm birth, no question, cerclage. Don't even think about it twice. No history of preterm birth, you did it and somebody who you just did it for other reason, I would put cerclage, or like in the previous slide, do vaginal progesterone and close observation every week or even more frequent than that. Further shortening cerclage. Now twins, and that's kind of like tricky a little bit here. Again, ultrasound 16 to 24 weeks, maybe you might even start before 16 weeks. Cervical length between 16 and 25 millimeter, no history of preterm birth, absolutely vaginal progesterone, no question. History of preterm birth, vaginal progesterone and close observation, further shortening to 15 millimeter or less cerclage. Okay? Now, don't forget, this 15 millimeter based on all the studies that said so far with twins, you should intervene at 15 millimeter. I told you I do intervene prior to that. I intervene if it's less than 25 millimeter. And my reasoning here is logical, that if twins who they have a higher incidence of preterm birth in comparison to twins, 9 times more, and now I'm using a number that I'm going to use a worse number for twins, for me, I cannot digest it. But I'm just giving you what the literature is saying. So if you want, yes, close observation until you get to 15 millimeters and do a cerclage. If less than 20 weeks and clinical cervical dilatation, now I'm not talking about ultrasound, for membrane bulging, take her and stitch her immediately. You have to counsel her that the success is not good. So this is important. No history of preterm birth, including myself, I would give vaginal progesterone. History of preterm birth, no, definitely I would go with the circulage. But you can do this outpatient. Now, cervical length now 15 or less. Well, everybody say you have to do circulage, okay? Especially if there is a history of preterm births. For whatever reason, patient did not want the circulage, you did not feel comfortable doing it, whatever reason you decided not to do it, then in this case, you have to observe it very closely. I would not advocate this, that's why I put it in a small font. No history of preterm birth, which is usually your more likely scenario, especially if you are following a patient who had an IVF. Literature so far tell you put vaginal progesterone. For me, personally, if this is a person who had an IVF, I would put the circulage. But you don't have to listen to me personally. If less than 20 weeks and there is clinical dilatation, then in this case, you have to put the circulage. Now, is there a place of amniocentesis prior to circulage? I just show you a few slides back that this study that was done in South Korea showed that there is significant amount of intraamniotic infection, and by using antibiotics, you cut down the risk and you increase the gestational age at delivery. Well, here is some guidelines for you. If you have a dilatic cervix and bulging membranes, especially in the presence of amniotic fluid sludge, I strongly recommend that you do an amniocentesis and send it for studies. What are the studies that you send? This is important. If you have a lab that can do you an IL-6, interleukin 6, that probably would be ideal. However, if you don't have it, you can ask for glucose level, because you know glucose goes down with infection, and you can consider less than 15 milligram per DL as your target number. Do white blood cell count. If you have more than 10 white blood cell count, more than 15, it's again an indication. Or when you do a gram stain, all this stuff, you can get it within less than an hour. So in any hospital that you go to, you should get the result immediately. If there is positive gram stain, then this is an indication. Or if you want, you can wait for the culture. Clinical suspicion of infection. Somebody comes with irritability and they have an abnormal discharge, no, maybe you can consider it. Or unexplained leukocytosis when you do the WBC count, when you do the CBC. Okay. Now, let's get to the management of now somebody that we established that they have preterm labor or premature rupture of labor. 3 important questions you have to ask yourself. Number 1, do we need to prolong the pregnancy? Okay. In another word, do we need to treat preterm labor or not? Question number 2, is there preterm labor or not? Question number 3, what to do? Okay, let's try to tackle each one separately. Okay. Question number 1, do we need to prolong pregnancy or not? You need to have adequate evaluation, good history and physical, but fast. Because if you have somebody here who has severe hypertension and she has a preeclampsia, it would be foolish to stop it. Ultrasound evaluation quickly, gestational age, placental location, amniotic fluid, no obvious anomalies. And it's very important here because if you have somebody who's coming in preterm labor and this baby is anencephalic, I mean, I don't think anybody would try to stop labor. Always remember, first, do no harm. This is what we have taken as an oath when we finish medical school. We do it everywhere in the world, and it's very important. Okay. We discussed before, preterm birth is the ultimate result of different biological pathways that will initiate preterm labor. Okay, so there is a reason why, although we may not see it, why is this person going into labor? Maybe it's in their best interest that they deliver the baby. That's something we don't know, so we have to always keep it in mind. It doesn't mean that you cannot treat preterm labor, but if you find you have to dig deep and try to find the reason why this person is preterm labor. Always remember, nature is always smarter than we. Okay. 2 types of preterm births indicated, as I told you, maternal or fetal jeopardy, severe preeclampsia, somebody who's coming with heavy bleeding, placental abruption, placenta previa, which is bleeding. And in this case, no, you don't stop labor. They have to be delivered. Spontaneous preterm birth, that's the one which is $1 million question. So there is no apparent maternal or fetal jeopardy. Treatment is indicated to prolong pregnancy. Of course, your first tool is always uterine contractions. Somebody put the patient on the monitor, look at the tracing. Oh, this patient is in preterm labor. Let's treat her. Well, hold on a second. Let's not go that fast. So there are rules that you have to follow. The contraction frequency would be traditionally 6 per hour or more. Practically speaking, I start at least to observe if I have 4 or more per hour, like every 15 minutes. Cervical assessment, clinical here, digital and speculum. Of course, you have to make sure that this person doesn't have placenta previa or no bleeding or ruptured membrane or anything. And if you need, you can do transvaginal cervical ultrasound evaluation, okay? In the US, I don't know if people among the audience are from other countries where they have fetal fibronectin, this could be also another tool. But I'm gonna assume here that you do not have fetal fibronectin, and that will gonna be the base of my next few slides. So digital examination, preterm labor symptom plus cervix 2 to 3 centimeter or more dilated or 80% effects, manage preterm. Don't waste time. Symptomatic, that mean contraction, which is the 4 or 6 per hour, but cervix is less than 2 centimeter or less than 80%, you can do further evaluation. Now comes the place of the transvaginal ultrasound cervical lens. Okay. Now, let's say preterm labor versus preterm contractions. So, why is important to differentiate between the two? Why do we need to really know whether are we really dealing with preterm contractions only, and I'm gonna treat the patient, or I'm really dealing with preterm labor? And that was really a very good study by one of the pioneers in preterm labor, which is Dr. J. Iams. Hospitalized patient for preterm labor, 30% resolved spontaneously. They didn't need any medication. 50%, they even want to falter. So you have to be careful about that. So the main challenge is distinction between true and false preterm. And here comes the role of the transvaginal ultrasound for cervical lens. Okay. Cervical lens is more reproducible than digital examination. I examine somebody and I have big fat fingers, and I call this person 1 centimeter. A nice person who doesn't have big fat fingers can examine the cervix and say, oh no, this is 2 to 3 centimeter dilate. So cervical lens is a cervical lens. It's not going to be different between Dr. X or Dr. Y. Inverse relationship, cervical lens and risk of preterm labor, we talked about that, takes place several weeks prior to clinical preterm. So I cannot emphasize the importance. You like to do it vaginally. This is a vaginal one, this is abdominal one, and you can tell definitely the vaginal, you can evaluate it much better. In addition, that the abdominal, you need a full bladder, and that can artificially make the cervix look longer. This is here when the cervix open, abdominal versus vaginal. You can tell here you cannot see anything. Okay, cervical length. We said inverse proportion to risk of preterm labor. And here it is, at 35 millimeter, preterm birth risk is less than 10%. Less than 25 millimeter, preterm birth is about 30%. Less than 15 millimeter, preterm birth is greater than 50%. I think I showed you this slide before. So, if we do a vaginal sonogram and the cervix is greater than 30 millimeter in somebody who's presenting with preterm labor, risk of delivery with 7 days is less than 2%. Okay, so what to do now? We are now into the practical part here. Regionalization, very important. You have to know what is the capacity of your hospital. Is your hospital be able to take care of a 26 weeks baby or not? If not, you may consider transferring the patient to a regional center, especially if you are practicing in a rural area. Antenatal corticosteroids, very important. It goes without saying, tocolytics and antibiotics. Now, okay. A little bit of basic science. I know it's not the favorite subject for anybody. Essentially, what is a contraction? This is a muscle cell, is a coupling of myosin and actin. So they contract. Why this happen? This is a slide probably you all have seen in biochemistry books. I don't think it's very practical for me to discuss it today. So here, what happens? Still a little bit challenging to read. So let's get to the bottom line. That's what you really need to do. Essentially, for contraction to happen, you need to have free intracellular calcium. Calcium should go into the muscle cell, from the outside to the inside. And that's usually done through cyclic AMP. Cyclic AMP decrease free intracellular calcium and do relaxation. So that would be your target to stimulate when you treat preterm labor. Tocolytic agents. In the US, there is really no medication approved for tocolysis. It's usually medications that were used in other indication, and they give us permission under something called off-label use at the FDA. Essentially, terbutaline is used for asthma. Magnesium sulfate used to be used for seizure disorder. Indomethacin is used for peptic ulcer. So all these medication are medication that are used for other reasons. So what is the rationale to use tocolytic? Is to provide short-term prolongation of pregnancy. What does this mean? This means that I'm giving the patient some time, so the corticosteroid that I give to help the maturation of the fetal lung is full in effect. And it's usually about 48 hours. These are your famous tocolytic agents. It's like calcium channel blocker, nifedipine, I believe in Egypt is Adalat, cyclooxygenase inhibitor, indomethacin, and ketorolac, IV magnesium sulfate, beta-adrenergic receptor like terbutaline and ritodrine. We do not use in the US the oxytocin receptor antagonist. I know that maybe some of you are using it, especially I heard that in some of the Gulf countries it's available, or the nitric oxide. It has not been FDA approved, so beyond research is not advised to be used in the US. Okay, magnesium sulfate, that's probably the most common one, especially now that we are talking about using it mostly for neuroprotection. What does it mean? That means that we give it to somebody who's in preterm labor to reduce the risk of cerebral palsy from prematurity, especially in moderately to severe cases. So, treatment protocol, we use it as a loading dose of 4 to 6 grams over 30 minutes, being very careful not to give it too fast. Maintenance dose 2 grams per hour may be increased gradually if needed to 3 to 4 grams per hour. Popular despite lack of evidence of its superiority and complex use because of neuroprotective effect. So mainly neuroprotective effect, but we are stealing it to use also preterm. That's what all the slides want to tell. Okay, when to use it? Somebody between 23 and 34 weeks when labor is about to happen. And not important here only for preterm labor, but also for preeclampsia and IGR. These are the most common. I don't know what you have in your institution, but you can use the betamethasone 12 milligram, 2 dose 24 hours apart, or dexamethasone 6 milligram, 4 dose 12 hours apart. Rescue dose if more than 2 weeks since the original and the risk of preterm birth continue. Steroids for preterm labor, I told you before, it is between 24 and 34 weeks. However, recently, or not really very recently, in 2016, we started to extend it to almost 37 weeks. Okay, antibiotics, is there a plate? Well, traditionally, this is what we learned from high-risk OB books, especially Christian Resnick, which is considered like the main book for maternal fetal medicine doctors. They say that has proven to be ineffective and except for treating group A beta strep. And the rationale here is that bacteria produce a microbial films in amniotic cavities that protect us from antibiotics. Well, that's the traditional thinking. Reservation, these are recommendations based on studies from the late 80s and 90s, did not include transvaginal ultrasound, sonographic short cervical length, in addition to intra-amniotic diagnosed by amniocentesis treated antibodies and repeat amniocentesis demonstrated effectiveness. So you have now an opposing view that no, maybe it's not a bad idea to use antibiotics. Okay. Definitely group beta strep prophylaxis and erythromycin-based products, as we're going to see in a few minutes. I know I might be exceeding my time now, but bear with me, there is a few more minutes. Now, I'm going to wrap up here. Preterm labor, 23 to 34 weeks. Persistent contraction with pelvic pressure, backache, regular uterine contraction on external tocometry, leakage of fluid, vaginal spotting. All these are presentation of preterm labor. Now we have somebody in preterm labor. What we're going to do? Fetal well-being. Make sure that this baby is alive first. Put a monitor. Perform basic ultrasound. You might have somebody who is further than what you think. Maybe somebody who's 38 weeks now. She's not really 34 weeks as you thought. Placental location. Are we dealing with a placenta previa? Is there a placental abruption? And very important, assessed for the evidence of pertinent coexisting condition, such as, is she infected? If she's infected, don't treat her. She needs to be delivered. If there is an abruption, if there is severe urinary tract infection, maybe then you can treat the infection that will take care of the problem. And then you perform internal exam or sterile speculum examination, in case especially of ruptured membrane. Cultures, you need to get the group beta culture and other cultures when indicated. Then you do a digital exam if there is no ruptured membrane and there is no placenta previa. Okay, now, preterm labor symptoms plus cervix, that is 2 centimeters or more, or 80% effacement, manage preterm. That means you're going to give them steroids, glycolysis, and antibiotic. Symptomatic symptoms, but cervix is less than 2 centimeters dilated or less than 80%, then you do further evaluation. That's come, as you saw before in the previous slide, the role of transvaginal ultrasound cervical lens. Okay, now, cervical lens at less than 25 millimeters, treat preterm. Don't forget, those people, you're going to tell me a few minutes ago you told us about circular. No, these people past the stage of the circular, past 24 weeks. Okay, so these people are in true, honest-to-God preterm labor. Cervical length, 35 millimeter or more, no preterm labor, just send her home, tell her to be careful. Cervical length between 25 and 35, further evaluation, more observation, keep her in the hospital, put her on the monitor, reevaluate the cervix after 12 hours. If you are in the United States or in a place where you can use fetal fibronectin, do fetal fibronectin. If positive, then treat with preterm labor. So that's why I told you I'm gonna tailor the presentation based on whether you have it or you don't have it. Now, contraindication to tocolysis, very important, of course. Nobody is gonna use tocolysis on a dead baby or a lethal anomaly, as I told you a few minutes ago, such as anencephaly, or non-reassuring fetal status. You put the patient on the monitor and she has a category 3 fetal monitor tracing, or severe preeclampsia, or maternal bleeding with hemodynamic instability, and chorioamnionitis. In this case, you do not use tocolysis. You deliver the patient, if anything. First line usually is recommended that you use either a calcium channel blocker, such as Procardia, or nifedipine, and NSAIDs, such as indomethacin. That's only the NSAID, indomethacin, or the ketorolac is only if pregnancy is less than 52 weeks. After that, you do not use. Okay, this is a nice summary of how you manage. You have somebody who is in preterm labor. Now we establish this person is in preterm labor. You give them magnesium sulfate for, and this is here for tocolysis. Of course, you have already started corticosteroids for fetal lung maturity. You give them magnesium sulfate as per protocol for neuroprotection. Adequate tocolysis, stop contractions, patient is doing fine, continue for 24 hours of magnesium sulfate, and then observe her for another day and decide whether you're going to send her home. Now, magnesium sulfate helped with neuroprotection, but did not help to kill the contraction or treat the preterm contraction. Okay, you stop it after 12 hours, and then if it is less than 32 weeks, you give indomethacin, it's very important. 32 weeks or greater, you give nifedipine. I hope this is helpful. And as I said, I have my slides available for you. If you want, just email. So you admit the patient to labor and delivery, corticosteroids, magnesium sulfate. This is just a summary slide of the previous graphs that I gave you. Magnesium sulfate for neuroprotection. If less than after 32 weeks, you don't need it. Tocolysis, if steroids not already received. Antibiotics, GBA culture, and you have to get an NICU consultation. Corticosteroids, initial treatment, we said, I think I showed the slide to be before. And you have to remember that therapy should not be withheld if delivery is anticipated. What it means, like if let us say I have somebody who comes to labor and delivery, I examine her, she's 6 centimeters dilated, I'm not going to use tocolysis, that would be foolish, okay? Then in this case, you still give her steroids for fetal lung maturity. Even if you give her one dose, probably you're not going to make it for the second. But one dose is better than nothing, and studies show that even one dose can make a significant and tremendous effect on neonatal outcome. All right. Okay. What about the maximum efficacy of steroids? It's usually 2 to 7 days after administration. The American College of OBGYN saying that if the patient is in recurrent preterm labor or any other indication such as such as preeclampsia, and it's been more than 14 days from the previous, and you can give them what we call it rescue dose, which is only 1 dose or 2 doses, whatever you need. Okay, this is again for you to remember. Okay, now, premature rupture of membrane. Quickly, pretty much the same as preterm. There are a few differences here. You have to realize what is the gestation age. If it's less than 24 weeks, are you really want to treat or you want to counsel the patient that the outcome is not very good? That's individual choice. Presence or absence of infection, presence or absence of labor, fetal presentation, fetal well-being, expectation based on fetal lung maturity, and cervical status by either visual inspection or doing a ultrasound. Now, expectant management, you need to buy some time between whatever gestation age you're going to decide, like let us say you're going to decide 23 weeks, 24 weeks, depending on what is your institution capability. Expeditious delivery, you do not do expectant management if there is any of this. Infection, abruption, category 3, fetal heart racing, advanced cervical dilatation, there is really no risk because in this case there is a risk of cord prolapse or extreme prematurity, less than 23 weeks. Antibiotics, definitely antibiotics. If you're not going to use it in preterm labor, it is indicated in premature rupture of membrane. GBS prophylaxis, which is usually a penicillin or amoxicillin, and if it's allergic, you use a cephalosporin if they don't have a history of anaphylaxis, or if they have anaphylaxis, then you have to do a culture and do clindamycin, and based on the culture, you might change it. Or extreme cases, you might have to use vancomycin. Otherwise, you use azithromycin, which is known as azithromax, and this is a dose, 500 daily for 2 days, followed by 250 for 5 days, 1 week. Or you can use erythromycin tablets, or erythromycin IV is a little bit difficult because it's IV irritant and can cause GI problems. So that is my presentation. I'm sorry if I have gone a little bit over time, but I'm ready for any questions. And this is my email in case you need me to send you a PDF of my lecture. I will be happy to do. And thank you very much again for the organizing committee. And I'm ready for your question.
Many thanks for Professor Mustafa Hassan. We are too late. I think we will postpone the discussion after the second talk, which is chronic hypertension with pregnancy by Dr. Munira Habli. Dr. Munira is Associate Professor, Director of Tri-Health Fetal Care Center, Maternal Fetal Medicine Division, and the co-chair of Prenatal Research Committee at Good Sam Hospital. So we have, this is also virtual lecture.
Good morning from the USA and good afternoon for my Egyptian colleagues. I would like to thank the organizing committee, especially Dr. Muhammad Kamal, for inviting me to be speaker in the Maternal Fetal Medicine Egyptian conference happening now in Egypt. Today, I'm going to speak about hypertension in pregnancy, mainly the new guidelines from the American College of OBGYN. I have nothing to disclose. We're going to speak about the new diagnostic criteria, treatment guidelines, outcome, and if I have time, gestational hypertension and preeclampsia, just the new guidelines. The Center for Disease and Control and Prevention, the CDC, estimated about almost one in 3 US adults, almost more than 68 million have chronic hypertension. This accounts for more than 3,050 deaths, and the cost is almost 93 billion in healthcare costs annually. Worldwide, this death and cost are even several fold greater than the United States. Chronic hypertension complicates about 2 to 6%, up to 260,000 of US births annually. The majority of pregnant women with chronic hypertension have mild disease, which is defined as hypertension, as blood pressure less than 160, 110, and no proteinuria. The rate of chronic hypertension over time increased by 67%, mostly in African American, which constitute about 87% of all chronic hypertension, secondary to obesity and advanced maternal age. The demographic in obstetric have changed, and this demographic and obstetric have changed the rate from 2 to 6 to almost 7 to 10 or even higher than that now. That is secondary to advanced maternal age during pregnancy were 20% more than 35 years and more than 5% more than 40 years of age, increase in pre-gestation diabetes, increase of secondary other medical disorder, whether heart, transplant, or lupus or renal disease, and increase in obesity, where 30 to 35% of pregnant are more has a body mass index more than 30, 5% has a body mass index more than 50. Also, chronic hypertension in pregnancy has significant maternal and neonatal outcome. There is a 24% increase in NICU admission, twofold increase in risk of C-section, which impact mom during subsequent pregnancy and during the current pregnancy. Increase the 2 to 3-fold increase in risk of maternal death, especially in African American, 2 to 3-fold increase in rate of preeclampsia and perinatal mortality as compared to non-chronic hypertensive patients. Because of this dramatic change in demographic over years, you could see as listed here, over 19 years, the American College of OBGYN has changed so much in management, treatment, prevention of chronic hypertension in pregnancy. The latest was in 2019 about chronic hypertension in pregnancy. In June 2020, they had a practice bulletin for gestational hypertension and preeclampsia also. What is not changed is the definition. It's mainly persistent. Chronic hypertension in pregnancy is defined as persistent hypertension after 12 weeks and after 6 weeks postpartum. Or if the onset of hypertension before 20 weeks is based on an office blood pressure measurement of more than 140 over 94 hours apart, or if the patient has used antihypertensive before pregnancy. Proteinuria definition also did not change, which is defined as significant protein, defined as more than 0.3 gram per day in a comprehensive 24-hour urine collection, or more than 30 milligram per mole in urine protein collected in a spot or random urine sample, What changed is those three upcoming. One, significant proteinuria should be suspected when a urine dipstick is more than +1. A more definitive testing for proteinuria by urine protein creatinine ratio or 24-hour urine collection should be done. Testing should not be repeated. Once you have significant proteinuria of preeclampsia, confirm that's it. We should not repeat the proteinuria again. Also, they have suggested that whenever we see those patients in first prenatal visit or pre-counseling, to make sure that there is no secondary hypertension. Some of the markers of primary hypertension is a gradual increase in blood pressure, lifestyle, obese, sedentary life, no exercise, alcohol, drug intake, family history of hypertension. But if we have other markers such as labile blood pressure, symptoms of thyroid disease, obstructive sleep apnea, history of substance abuse, or absence of family history, they recommend workup for secondary hypertension. So this is a slide that shows some of the causes of secondary chronic hypertension: renal, collagen vascular disease, diabetes, thyroid, adrenal adenomas, and more to come. The new thing that they have classified is mainly classification of chronic hypertensive pregnancy into mild and severe. Mild defined as blood pressure between 140 to 150 over 90 and 109, and severe, it is mainly defined as blood pressure more than or equal to 160 over 110. Criteria for mild or low risk chronic hypertension is if it's essential hypertension only, age less than 35 years, duration of hypertension less than 5 years, blood pressure controlled either with no medication or one medicine, no prior adverse pregnancy outcome, good compliance. These patients can be managed by general OBGYN in general. Still, despite its low risk or mild chronic hypertension, they carry significant risk in pregnancy. They are a higher rate of superimposed preeclampsia, 10 to 15%, exacerbation of hypertension. They are still at increased risk of preterm delivery, IUGR, perinatal death, and placental abruption. These patients will be managed honestly like any other patient. We will do the first trimester screening, second trimester fetal anomaly, ultrasound for growth and fluid, usually fluid weekly, and ultrasound at every 4 weeks starting at 28 weeks, and antenatal testing. Umbilical artery Doppler if estimated fetal weight mainly less than the 10th percentile by ultrasound. What about severe hypertension? What's the criteria that has been listed? The severe hypertension criteria for high risk, mainly if they have severe hypertension prior to pregnancy or at their first prenatal visit, requiring more than or equal to 2 drugs to control their blood pressure, secondary hypertension, if they have target organ damage such as dyslipidemia, diabetes, morbid obesity, cardiac disease such as left ventricular dysfunction, ischemia, if they have dialysis or any renal disease or retinopathy, or if they have poor outcome in prior pregnancy, less than 34 weeks, such as perinatal death, preeclampsia severe, abruption, or congestive heart failure, peripartum cardiomyopathy. High risk, those high risk or severe chronic hypertension in pregnancy, they are at risk of maternal and neonatal outcome. They are more than 50% will have superimposed preeclampsia. They will have exacerbation to severe hypertension, higher rate of preterm delivery, IUGR, abruption, perinatal death. 3 to 15% could develop pulmonary edema, 1 to 2% could end up with renal failure or dialysis, 0.5 to 1% could have strokes or retinal injury, and less than 1% maternal death. Other maternal complication that could happen, as mentioned, maternal death about less than 1%, maternal cardiovascular complication, heart failure, stroke, need for ventilation, renal failure, MI. Most of these patients require prolonged hospitalization, more than 6% and 9%. Now, whether treatment, when we treat, yes, they could be under treatment of 2 or more medication in order to control their blood pressure. No literature up till now showed how the outcome or this treatment can be influenced by the treatment. This is some of the target organ damage: retinal, congestive heart failure, left ventricular hypertrophy, strokes, and the glomerular scar or sclerosis in the renal kidney, At first prenatal visit, some factors that said that this pregnancy in the counseling help us that will be has a poor outcome is as following. If we have a creatinine more than 1.4 milligram per dl, proteinuria more than 3 gram in 24 hours, anemia, hemoglobin less than 9, if they have active lupus or any vasculitic disease, if they are on dialysis, if we do an echo and they have severe left ventricular dysfunction, if they have on EKG any MIs, poor compliance, long history of chronic hypertension, and very prior poor history of adverse pregnancy outcome, especially history of preeclampsia less than 34 weeks. The first prenatal visit in these patients is, I name it always $1 million visit, because a lot of testing will be done. And this is include hemoglobin A1C, EKG, maternal echo, renal function, lipids, thyroid, and other tests based on if there's secondary disease, and make sure what are the medication are used. In addition, these patients should be counseled extensively about complications of pregnancy, just listed preeclampsia, preterm delivery, IUGR, what are the maternal and neonatal outcome, and these patients are usually have frequent visits, a lot of antenatal testing, and the timing of delivery is variable, which I'm going to mention the new guidelines based on the blood pressure control. Most of the patients, we do for them EKG and echo, especially if they have chronic hypertension more than 5 years, age more than 35, if they have pre-gestational diabetes, BMI more than 35, prior history of heart failure, pre-existing hyperlipidemia, or a family history of hypertensive cardiovascular disease. We do usually EKG and or fetal echo, maternal echo, sorry. We monitor them very, very, very closely. They have a frequent prenatal visit for blood pressure check, and now we do sometimes home blood pressure, liberal hospitalization to control their blood pressure. We usually achieve a desired blood pressure target between 140, 160, 90 to 110. We do ultrasound every 4 weeks till 28 weeks, and then every 2 weeks till delivery. Weekly AFI and Dopplers if there is IUGR, and NST or biophysical profile, we start them at 28 weeks or earlier if indicated. Timing of delivery based on the American College of OBGYN is as following. Keep in mind, there is no randomized trial that have evaluated the optimal timing of delivery of these patients for the low or high risk patient. We deliver patient at 38 to 39, 6, 7 weeks of gestation if they are having chronic hypertension on no medication. If they have chronic hypertension with medication that is well controlled, we deliver them between 37, 39, 6 weeks. If they have hypertension that is severe and difficult to control, delivery at 36, 37 weeks, unless need to be delivered earlier. All of these unless indicated to be delivered earlier. If we have a chronic hypertensive patient that developed preeclampsia with or without severe feature, if severe features are present, then delivery at 34 weeks or earlier as indicated. If she is chronic hypertension with superimposed preeclampsia without severe features, there is an opportunity for us to do expectant management till 37 weeks, but as indicated earlier, if blood pressure cannot be controlled or it still have severe range blood pressure during this expectant management. Prevention recommendation in the American College of OBGYN, low dose aspirin, calcium supplementation, at least 1 gram per day for women with low calcium intake are recommended for prevention at high risk group. Aspirin should be taken low dose. There is no yet optimal dose that has determined between 75 to 162. In general, most people use 81 milligram baby aspirin. It should be administered at bedtime. It should be initiated early after diagnosis pregnancy, in general after 12 weeks, but they recommend before 16 weeks. Aspirin should be considered to be continued until delivery. In summary, always we need to have counseling prior to conception and at first degree, preventive in all patient aspirin, calcium, and I will speak about investigational prevention of statins, close observation for low versus high risk chronic hypertension. Both has the complications of preeclampsia, IUGR, abruption, but the frequency is different. Timing in delivery in general, 39 weeks for uncomplicated, on treatment 38 weeks, superimposed preeclampsia 34 to 37 weeks based if there is severe or not severe features that are included in the diagnosis of chronic hypertension with superimposed preeclampsia. I can give, this is all what is summarized in this flow chart. We can send it for you if somebody requested that. what was the changes in chronic hypertension with superimposed preeclampsia in the new recommendations echoed? As we know, there is about overall 20% of chronic hypertension will develop superimposed preeclampsia. And it's mainly in those that has severe systolic blood pressure more than 100 and if they had severe preeclampsia. But if their diastolic pressure it is less than 100, they are at still at 20% only risk of superimposed preeclampsia. This is a nice paper presented by Sibai, which shows if they have 200 patients with mild chronic hypertension, what is the percentage of those patients that will develop severe exacerbation of hypertension? They divide them into three categories: those that have decreased mean arterial pressure, unchanged, and those that has increased mean arterial pressure. The highest risk, if there is increase in mean arterial pressure during pregnancy, more than 1/3 will develop severe exacerbation of chronic hypertension. And if the mean arterial pressure is unchanged, only 16% will develop exacerbation of chronic hypertension. If it decreased, it's the lowest, it's 4% that only develop exacerbation of chronic hypertension at term. The criteria for chronic hypertension superimposed preeclampsia is new onset of any of those severe features: headache, altered mental status, neoproteinuria, or a blood pressure that is uncontrolled despite medication, abnormal creatinine. These are the all criteria. What about antihypertensive therapy? Always the question, do I continue on a chronic hypertension patient, the medication? If it's mild or severe, what do we do? It is mainly this antihypertensive in pregnancy. It's like the elephant in the room. It's under always complete discussion and controversially. And as seen here, we don't know what would be the best, as mentioned by the American College of OBGYN. And the reason is, why do we have conflicting recommendations for chronic hypertension? One, because there are only few small trials and limited data to guide us in the management of mild to moderate chronic hypertension in pregnancy. Available data also did not demonstrate any significant maternal or perinatal benefit of treating mild chronic hypertension. From non-clinical trial, we have in the Cochrane review, they did a meta-analysis in 2014. It showed that treatment did not result in any fetal benefit or harm. Antihypertensive therapy only decreased the incidence of severe hypertension by 40 to 60%, the need for additional drug by 40 to 70%, and also did not increase delivery of small gestational age if we treat those patients, and did not reduce perinatal mortality or rate of preeclampsia or abruption, did not benefit treatment of mild to moderate chronic hypertension, did not benefit decreased rate of IGR, preeclampsia, and other work complications, pregnancy complications. Is there is any evidence of clinical trial about antihypertensive therapy for mild chronic hypertension, if there is any benefit? There is a few randomized clinical trial in pregnancy. Most of them are underpowered or design limitation. In 2015, we have the famous the CHIPS, or the less tight versus tight control hypertension in pregnancy. And this is an open international multi-center trial involving singleton between 14 to 33 and 6 weeks of gestation, only low-risk chronic hypertension with non-proteinuria pre-existing or persisting preeclampsia or gestational hypertension. Women were randomized to two groups: less tight, target diastolic blood pressure less than 100 milligram, and the tight control is the target diastolic blood pressure less than 85 milligram. The primary outcome was pregnancy loss or admission high neonatal care for more than 48 hours during the first 28 days postnatally. Secondary outcome was serious maternal complications such as preeclampsia, blood transfusion, C-sections, occurring up to 6 weeks postpartum or until hospital discharge, whichever was later. comparing, this is a table showing less tight versus the tight control, which is diastolic blood pressure less than 85. There was no difference between primary, secondary outcome, or severe hypertension among the two groups. The only difference when they combined the general SGA together, that the tight group, which is when we control blood pressure on those mild chronic hypertension, there is a slight increase in risk of having IUGR. Mainly is seen in beta blockers and could be secondary to reduce in the mean arterial pressure that increase the risk of having small for gestational age in this population. Thus, after the CHIPS study, the SMFM say, despite all of that, still we remains uncertain, and we're not gonna change our recommendation, which is clinician continue to following existing guidelines for management of pregnant patient with mild to moderate hypertension. What are these guidelines? More still confusion until we have the ongoing CHAPS study now in the USA. Treatment and blood pressure control, especially in mild chronic hypertension, there is uncertain benefits and safety in pregnancy. We have conflicting recommendation. Limited study showed in regard to potential benefit and safety. The SMFM CHIPS statement remains uncertain, and we need large RCT, which is there is the CHAPS, not the CHIPS, CHAPS study. Here it is, that is ongoing in the USA. The new ECOG say the same thing. It is reasonable if a patient is pregnant with mild chronic hypertension, no comorbid factors, it's very reasonable to withhold or discontinue the treatment, but this is a low quality evidence. The only thing they say is women with severe hypertension who become pregnant or are planning to become pregnant should be transitioned to procardia or nifedipine during pregnancy. Methyl-dopa is less effective and not desired, and women with hypertension who became pregnant should not be treated with ACE inhibitors, ARBs, or direct renal inhibitors. This is a table from the American College of OBGYN showing the labetalol, nifedipine, how they are first-line treatment. Methyl-dopa, yes, it is safe, but it has been shown to be ineffective, especially if they have severe exacerbation of chronic hypertension. And hydrochlorothiazide to be used only as second-line or third-line agent. And you have the dosing and all the side effects on this table. Why we don't use ACE inhibitor or ARBs? Because it can cause fetal anomalies such as clavicular or bone abnormalities, IUGR, oligohydramnios, fetal renal failure, and dysfunction. And sometimes these babies are born with that will need neonatal dialysis. This is a protocol for severe hypertension. I'm not going to go through it, but we can print that for people if needed. This is from the American College of OBGYN, just summarized. These are some of the drugs that we could use in patients who have comorbid disease such as diabetes, renal disease, cardiomyopathy, or thyroid disease, and what are their dosing in order to have renal and cardio protection and during pregnancy, and these are safe. We can give also this table if needed. What are the under investigation prevention that we are using, which is mainly the statins? This is the new thing that is ongoing now. Statins is first generation, such as lovastatin, pravastatin, and fluvastatin. They don't cross the placenta, and they are most rigorously tested in controlled the clinical trial and demonstrate improvement in non-pregnant cardiovascular outcome. They are absorbed rapidly, following oral administration with a peak plasma within 4 hours usually for treatment. Currently, the US FDA statins are category X, that means contraindicated during pregnancy. Human studies showed that fetal malformation is no higher than the background risk of population. A new study recently by Lefouque et al. Enrolled the 20 patients with the antiphospholipid syndrome and poor obstetric history in a prospective cohort, compared with patients in control cohort, those who received paravastatin, they have improved in uterine artery Doppler, decrease in their systemic blood pressure, delivered infant with higher birth weight and at more gestational age. As you see, the statin was 36 and the non-statin group was 26 weeks of gestation. That's almost a 10-week difference in that. There is in most trials that has been published, and there is Majid Constantine just published recently a new article shows that there is no identifiable maternal and neonatal safety risk. Rate of preeclampsia and indicated preterm delivery were decreased despite these studies are not powered for that, and the concentration of placental IGF were increased and those of S-FLIT and S-engine were decreased in subject receiving paravastatin. That means summary of the American College of OBGYN published in 2019 is level 1 pregnant patients should start the aspirin as early as 12 weeks. Initiation level B evidence is that initiation of treatment should be considered, especially if the patient has severe blood pressure more than 160, 110, or with comorbid disease, whether mild or severe hypertension. Acute antihypertensive management protocols has been mentioned and also requires hospitalization to stabilize, and timing of delivery, as I discussed briefly, that is what's recommended. Thank you. If we have any.
I think this session can be considered as a reference for two main topics in obstetric, preterm labor and chronic hypertension. Can we open the floor for discussion? Is Dr. Munira or Dr. Mustafa is available? Not online. Any questions for Dr. Munira? Not online. Any questions for Dr. Munira?
I'm online. Good morning.
Thank you, Dr. Munira, for your nice presentation. They ask if they can get the last three tables.
Absolutely. Absolutely.
They ask if they can get the last three tables.
Absolutely, we can give them.
Okay. By email, please, Dr. Munir. You can email Dr. Muhammad.
Yes, we'll do inshallah.
Inshallah.
It's an honor to be present in this conference, by the way.
You are welcome. We hope to see you live next year, inshallah. Inshallah. Any questions? Thank you, Dr. Munira. By this, we have the end of the third session, and we invite Dr. Dia Nashar and Dr. Ahmed Khidr for the fourth session. Thank you.
Hello, I'm Nick Vraknis, working as a professor in the University of Athens Medical School, and I am also a visiting reader at St. George's University of London and ISOG Validation Task Force Chair. My presentation today is from CSP to CC, and I thank very much
بسم الله
the
الرحمن الرحيم.
Egyptian
نبدأ
Fetal
الجلسة
Medicine
الخامسة.
Foundation
The first
for
speaker will
this
be
invitation.
Dr. Nikos
We'll
Lecture
start with a few
from
things
Greece.
about
He
the
will talk us
anatomy
about
of
the
the
neurosonography
CSP.
from
Hello,
CPS to
I'm
CC.
Nick. Hello, I'm Nick Vraknis, working as a professor in the University of Athens Medical School, and I am also a visiting reader at St. George's University of London and ISOG Validation Task Force Chair. My presentation today is from CSP to CC, and I thank very much the Egyptian Fetal Medicine Foundation for this invitation. We'll start with a few things about the anatomy of the CSP, the cavum septum pellucidum, which is the space between the leaves of the septum pellucidum that is filled with cerebrospinal fluid. The margins of the CSP are laterally the anterior horns of the lateral ventricles, as we can see here, and superiorly the corpus callosum and inferiorly the fornix. So we can see here the corpus callosum here. And again, we have to be careful because this view is normal and we can see here the CSP. However, this view is a few millimeters further down on the brain, on the axial view, and then it's not the CSP here. The CSP is just above because we can see the continuity of the brain with this line. So we have to move a few millimeters up depending on the gestational age in order to visualize the CSP as shown on the top image. So these on the bottom image are fornix columns. If we use all three views, the axial, the mid-sagittal, and the coronal view, 1, 2, 3, then we can visualize the cavum septum pellucidum as shown here and here and here with normal size, and these are the lateral ventricles on the coronal view. Certainly there are anatomic variations, and these anatomic variations of the septum pellucidum are related to the size and also anomalies of the vicinity of other structures in the vicinity. In particular, there are different names for the cavum septum pellucidum, like the cavum verge and cavum velum interpositum, that are different parts of the cavum septum pellucidum. Going now to the anatomy of the corpus callosum is the largest commissure connecting the two cerebral hemispheres, the corpus callosum. It's a broad plate made up of tightly packed axonal fibers crossing from side to side the brain. And here on the picture, we can see on the black and white picture the particular parts of the corpus callosum, which are the rostrum here on the front and the genu, and then is the body, the isthmus, and the splenium. The development of the corpus callosum begins at 12 weeks in the region of the genu and then processes posteriorly. So rostrum is the last segment to develop, and the corpus callosum is completed by 18 to 20 weeks. So if we have a look at the brain with some special studies of miscarriage fetuses, we see that by 13 weeks we cannot see any fibers of corpus callosum. Then this perpendicular, it starts developing at 15 weeks, and by 17 weeks the development is almost complete, because it is completed by 20 weeks. And here in our picture, we see a different appearance, not the corpus callosum as shown here, but the CSP appearance from second trimester and earlier 12 weeks, as we can see on the first column here. This is the transventricular, and this is the transthalamic view. And then as we move at 21 weeks, here and here, we can see the corpus callosum on both views, and eventually at 32 weeks, how the corpus callosum is visualized. How the CSP is visualized. Now, concerning the development of the CSP is fully formed from 17 weeks of gestation. It is detectable between 18 and 37 weeks. So if you cannot see the cavum septum pellucidum, the CSP, after 37 weeks, that does not mean that there is any issue. It's just that the cerebrospinal fluid is absorbed, but should be seen in all fetuses by 36 weeks of gestation. But then the statistics drop, as you can see here. But still, there are babies that the CSP, the cavum septum pellucidum, can be visualized after birth, but is a very small percentage of fetuses. The development of the CSP is closely related to and dependent on the development of the corpus callosum. So if you have a normal callosum, you usually have also a normal CSP. And the presence of the CSP indirectly indicates the presence of corpus callosum. And when the CSP is absent, incomplete agenesis of the corpus callosum, or if it is absent, still there may be the corpus callosum present, and this is the case of septal agenesis. There are charts about measuring the corpus callosum, and you see how it changes, not very much in millimeter, how the CSP changes, not very much in millimeter, as you can see here during the late second and third trimester. But in most cases, as you are aware, we visualize the CSP, and if we are happy with the size in our routine anomaly scan, we don't go for a measurement. The significance of cavum septum pellucidum is important as it is a landmark in the evaluation of the fetal neural axis in the second and third trimester. And the cavum septum pellucidum reassures the presence of this cavum septum pellucidum, shown here with lateral ventricles in a coronal view, that the central forebrain development is normal, while absence is associated with several central nervous system anomalies, and then we need to go for an investigation with MRI or send the woman for an expert opinion, expert in fetal brain. And the best planes to assess are the transventricular and transthalamic planes, the cavum septum pellucidum, and obviously we have to get all the views, the axial and the mid-sagittal and the coronal view if possible, so our evaluation will be complete. This is an ISO guideline updated in 2020, and it is the sonographic examination, the title of the guideline of the fetal central nervous system. So in the screening, we need to do an axial view and check the CSP. If the CSP is normal, then we move to assess the other structures of the brain. If it is abnormal, then we have to check the CC in mid-sagittal view. So we change plane from axial view, we move to CC in mid-sagittal view. If that is normal, then it is okay to move to our next plane of assessment. And if it is though abnormal, the CC, then we move for a detailed scan from a neurosono expert, and we give a guarded prognosis to the parents. The abnormalities of the CSP are either a genesis of the CSP. It may be a presence of the CSP, but there may be absence of outer wall in this case. So there is a continuance of frontal horn. If we cannot visualize it, then it may be the case of a complete agenesis of corpus callosum. If we have the case of a small CSP, this is part of cases of partial agenesis of the corpus callosum and not a complete agenesis of corpus callosum. While if we have an enlarged cavum septum pellucidum and a large CSP, this can be a normal variant. There may be a cyst of CSP or a genetic condition may be underlying. And here we have a genesis of cavum septum pellucidum. We can see here that there are no walls and the ventricles are here. So if it is isolated and we can see the CC, then this is a good prognosis. However, there may be severe brain dysplasia involving the optic root and other endocrine disorders, like in the septo-optic dysplasia, where a non-visualization of the CSP is noted. There is a squared-off morphology of the frontal horns, and this is associated with optic nerve chiasm, hypoplasia, and hypothalamic pituitary dysfunction, ADH, and so on. Concerning schizencephaly, there is a cortical defect that extends to the ventricles. 2/3 of the cases, in 2/3 of the cases, the CSP may be absent, and this case of schizencephaly needs an MRI. In our differential diagnosis, we have to take particular care about the lower part of this cavity of the lateral ventricles on the coronal view, what is the shape, and this guides us towards the diagnosis. Another case of agenesis of cavum septum pellucidum is lobar holoprosencephaly, is the least severe variant where the CSP is not seen. The intrahemispheric fissure is seen is not seen anteriorly. So we haven't seen, we cannot see this line here. Here we can see the line that continues, but we cannot see this line. However, the mid and posterior parts of the IHF, the intrahemispheric fissure, are seen, and the frontal cortex is continuous across the midline here, and the anterior horns of the lateral ventricles are continuous across the midline here. This is not CSP, are the anterior horns, as also were shown earlier. If we have partial agenesis of the corpus callosum, that is in the case of a small cavum septum pellucidum on the axial view, the posterior parts of the corpus callosum are usually absent. There may be hypoplasia, as we understand in these cases, and these will be initially visualized by just checking the size of the cavum septum pellucidum, but as there are charts, we can measure it and put it on charts depending on the gestational week, and then we can speak about the agenesis, the small cavum septum pellucidum, which in most cases hides and partial agenesis of the corpus callosum, or a callosal hypoplasia, which is an underdevelopment not of a part of the corpus callosum, but the full corpus callosum. So we can see examples here. Here we have a partial hypoplasia, because the posterior part is missing. While in other cases, the full corpus callosum may be small, so this may extend, but the size may be small on the anterior and posterior part of the corpus callosum. That's the difference between the partial agenesis of the corpus callosum and the callosal hypoplasia. Sometimes we may have an enlarged CSP, where a cyst may be also associating this enlargement of the CSP. Can be a normal variant, should be more than 95th centile if we measure the CSP and put it on the charts shown earlier. The cyst is not associated with a corpus callosum anomaly. We need to do HCG arrays because genetic conditions may be underlying. So what happens if we don't see the CSP? Then we have to move from transverse to mid-sagittal view and evaluate the corpus callosum. If it is present, then that is okay, because there is 1% risk or less of developmental abnormality. If it is absent, depends on our level of expertise. And then we'll refer for further evaluation in a neurosono expert and MRI. This is a slide that there are different abnormalities of corpus callosum. Here we have a complete agenesis of corpus callosum. This is a mid-sagittal view, so there is a complete agenesis. Here we can see partially the corpus callosum, so this is a partial agenesis of the corpus callosum. Here the corpus callosum looks thick, and if the corpus callosum looks thick, again is something that needs further investigation, because a dysplasia may be hidden. And again, here there is a thick dystrophic corpus callosum here. And here we have a hypoplastic corpus callosum, a very thin corpus callosum, but is the full length of the corpus callosum there. So we have to evaluate very carefully. And also we see the abnormalities for these two cases on the coronal views, here and here. The corpus callosum should be evaluated at or later 20 weeks. It's very, very important to rule out the complete agenesis of the corpus callosum, because in partial agenesis, the prognosis, as we'll see, can be better. So we have the different types of the complete agenesis of corpus callosum. If there is an early stage for brain defect like holoprosencephaly, there may be commissural axons missing and cannot reach the midline. So this is the Walker-Warburg syndrome. There may be commissural axons that do not cross the midline, like Probst bundles, and this is an example that a large brain cyst is there and has developed this formation. Or there may be a distraction after proper formation, like in tumors or like Lyon syndrome. So if we would like to remember by heart indirect signs to suspect the agenesis of the corpus callosum, in the transverse view, first of all, which is our standard view, there may be an absent CSP. There may be our well-known tear-shaped lateral ventricles. There may be an upward displacement of the third ventricle because of the anomaly and the absence of CSP. This has been displaced upwards to the brain structure. Or maybe a distortion of this continuance that I showed earlier of the intrahemispheric fissure. If we move now, because there is an absent CSP to the coronal view, then we may have a bullhorn or bicycle handle anterior horns, means like the child that is holding a bicycle or ourselves, the horns are in distance compared to the central line, and this gives the impression of bicycle handle or bullhorn. And again, because the ventricle can be displaced, this has a diamond shaped this time with many angles around, and obviously we cannot see the corpus callosum because is agenesis the case we are discussing. So these are the very well known to the expert audience of the Egyptian Fetal Medicine Foundation group. The bullhorn or bicycle handle anterior horns are shown on the coronal view only. And finally, other indirect tips to suspect agenesis of corpus callosum in the mid-sagittal view. Again, there will be an absent CSP, cavum septum pellucidum. There will be, of course, is agenesis no corpus callosum. There will be no pericallosal artery. It may be a dorsal cyst sometimes, and there may be a radiate pattern of brain fibers, as we call it, the sunburst sign, but this is on the third trimester. We will not see it during the fetal anatomy scan. I don't have pictures in these last three slides because I want you to visualize. These pictures were shown earlier, the majority of them, so I want you to visualize these findings on the different views: axial view, mid-sagittal view, and coronal view. So here is our relationship between corpus callosum and CSP pathology. So if everything is present, CC and CCSP, the brain is normal at the plane assessed, which is the transventricular plane and then the transthalamic plane, but mostly we work on the axial view on the transventricular plane. If there is a complete, if the corpus callosum is absent and the CSP is absent, then we are talking about a complete agenesis of the corpus callosum. If the corpus callosum looks abnormal and the CSP looks abnormal, then we are talking about a partial agenesis of the corpus callosum, and we can see half of the pericallosal artery during our transvaginal scan or our abdominal scan when we put the power Doppler on. And if the corpus callosum is present, but the CSP is absent, then we are talking about the diagnosis of septal agenesis. So my take-home messages, we have to start our screening with our axias, with our axial views and the transventricular plane. We have to make sure that the CSP that we are looking has a normal size. We always assess CSP and CC after 20 weeks. Partial agenesis of the corpus callosum may escape diagnosis. Mid-sagittal view is the most informative one, and we described the findings. The prognosis is unpredictable. An array CGH is indicated in all these cases, and we have to remember the agenesis of corpus callosum prognosis can have a normal outcome in 70% of the cases. Thank you very much again for the invitation, Professor Mohammed Kamal and the board, and all my friends that are in Cairo and in Egypt, and I look forward to see you next time. I hope that in one of our meetings this will be in live. All the best, take care. Bye-bye.
Thank you very much, Dr. Nichols. هيستمر معانا ولا في أسئلة مش أونلاين؟ اللي هي مسجلة. Next speaker will be Dr. Radwa. Dr. Amara Radwan, and she will address us about the sonographic overview of posterior fossa. This session will be ended. شكرا والله مش موجودة نشوف. شكرا.
بسم الله الرحمن الرحيم. أنا اسمي مروة رضوان شاهين، أنا استشاري نساء وتوليد في مستشفى الجلاء التعليمي والهيد اوف ديبارتمنت بتاعت الالترا ساوند وفيتال ميديسن هناك، وبرضه ممبر في الفيتال ميديسن فاونديشن. اتشرف بوجودي يعني اتشرف بحضوري في وجودكم ان شاء الله. First of all, I would like to thank Dr. Mohammed Kamal, head of Egyptian Fetal Medicine Foundation, for his kind invitation to be a part of this international conference. Second, I would like to thank my dear colleagues of the members of the Egyptian Fetal Medicine Foundation for their great effort and support in doing this international conference on this outstanding basis. Our lecture today is going to be about the posterior fossa malformation. Posterior fossa is one of the most important features of the brain structures, but it was not evaluated properly until the last decade, when it became so important because it has a lot of malformations that already predisposed many congenital abnormalities and affect the life of several babies, especially postnatal. Our objective today will be about demonstrating the importance of posterior fossa to clarify the different congenital common malformations and demonstrate other congenital anomalies associated with it and recognize their effect postnatal. First of all, we should take care that posterior fossa malformation, to be evaluated correctly, you should be familiar with the anatomical and embryological origin of its structures. This is very important to understand the malformations and how it was formed. Embryologically, أنا مش هتكلم كتير في الامبريولوجي، أنا عارفة إنه طول عمره معقد وبيعمل لنا مشاكل، بس embryologically كده the posterior fossa is composed mainly of the cerebellum, which is consisting of cerebellar hemispheres and worms, with cerebral peduncles, fourth ventricle, and the brainstem containing pons and pulp, the cisterna magna and the tentori. All of these structures جايين اصلا من حاجه اسمها رامبن كاثرين. احنا عارفين زي ما حضرتك هتشوفوا دلوقتي في السلايد اللي بعدها البرين originated من 3 origins: البروزن كاثرين، الميزن كاثرين، والرامبن كاثرين. الرامبن كاثرين هي الجزء المختص بمحاضرتنا النهارده اللي هو مسؤول عن الريسبونسبل افورميشن اوف posterior fossa. الرامبن كاثرين بتاعنا بينقسم بعد كده لميتن كاثرين، تمام، اللي بيطلع منها السيربيلم والبونز والابر بارت اوف ذا فورث فنتريكل، whereas the myelencephalon originating the bulb and the lower part of the fourth ventricle. In 6 weeks of gestation, the pontine flexure arises with formation of the anterior and posterior membranous areas. And the anterior membranous areas gives rise to the cerebellar worms, and posterior membranous area gives rise to the cisterna magna and what is called a Blake's pouch. Blake's pouch is very important structure in the posterior fossa because it can يعني تخلي نلخبط في السيسترنا ماجنا، وممكن نتوقع انها ممكن تكون فيها دايلاتيشن في حين انها ممكن تكون هي البليكس باوتش. النقطه كمان المهمه ان البليكس باوتش في حد ذاتها يعني البليكس باوتش سيست في حد ذاتها is not a malformation، بس هي ريسك فاكتور مهم جدا لوجود other malformations في البرين. البليكس باوتش من الحاجات المهمه اللي لازم نبقى عارفينها عنها ان احنا ممكن نشوفها في الفيرست ترايمستر وايرلي سكند ترايمستر، لكن actually it disappears around 16 to 18 weeks of gestation, leaving fenestrated fourth ventricle. طيب علشان نشخص posterior fossa malformation, first of all we have to be familiar with the normal anatomy of the posterior fossa. Here is we can see the cerebellum, which is like a figure of 8 in English, okay, composing of 2 cerebellar hemispheres. This is the first and this is the second, with echogenic structure in between called the cerebellar worms. The cystic area posterior to the cerebellum is called cisterna magna. This hypoechoic area between the 2 nuchal folds is called the nuchal fold, and here is the skin and bone. Okay. There is another structure very important and بيعمل لنا برضو لخبطه اللي هو الفورث ventricle. ده عندنا هنا السيربيلم برضو التو سيربيلر فيرمز هيمسفيرز والسيربيلر فيرمز الايكوجينيك في النص، وادي السيسترنا ماجنا بتاعتنا، وهنا هنلاحظ ان في جزء صغير سيستيك شادو كده بيمثل الفورث فنتريكل. الفورث فنتريكل ممكن نشوفه بسهوله في الفيرست ترايمستر، لكن المفروض ان هو بيبقى ديلينييتد او بيختفي بارشلي في السكند ترايمستر، وعشان كده ممكن واحنا بنعمل السكند ديتيلز انومالي سكان في السكند ترايمستر ما بين 20 ل 22 اسبوع ممكن ما نلاقيهوش، وهو ده الطبيعي ان احنا مش بنشوفه. طيب البوستيريور فوسا مليانه طبعا ايه مشاكل ومليانه مالفورميشنز، بس اهم حاجه وات از كومن از كومن. عشان كده احنا هنركز في محاضرتنا النهارده على الموست فور كومن مالفورميشنز، وهم الداندي ووكر، الميجا سيسترنا ماجنا، بليكس باوتش سيست اند فيربين هايبوبليزيا. دول كلهم هنلاحظ ان هم بيمثلوا الجزء السيستيك في المالفورميشنز. في انذر مالفورميشنز بس بتبقى ايكوجينيك او بتبقى ناتجه عن عدم وجود السيسترنا ماجنا، خلاص، زي السيربيلر هايبوبليزيا، الفيرمين اجينيسيس، والرامبن كيفالوساين ابسس. المهم في البوستيريور فوسا مالفورميشن انها كان بي ديتكتد او كونفيرمد او سسبكتد حتى في الايرلي فيرست ترايمستر، يعني من 11 ل 14 اسبوع. وده مهم بالنسبه لنا ان احنا في الفيرست ترايمستر سكريننج اللي احنا بنعمله تو اكسكلود الداون سيندروم او الترايزمس بصفه عامه، وي كان ديتكت برضه البوستيريور فوسا مالفورميشن. الانكريزد fluid in the posterior brain ما بين 11 to 14 weeks, particularly in cases of non-visibility of septation dividing the future fourth ventricle from cisterna magna, is very important and can predispose or be risk factor for Dandy-Walker malformations and other chromosomal aberrations. In fetuses with Dandy-Walker malformation, the median view of posterior fossa, if it was not possible to visualize the choroid plexus correctly, this can predispose to the formation or confirmation of diagnosis of Dandy-Walker malformation. الدايجنوزس is best done بالترانسفاجينال، عشان كده الترانس ابدومينال ما بنعتمدش عليه في الفيرست ترايمستريك انومالي سكاننج او السكريننج اللي احنا بنعمله في الفيرست ترايمستر. better to be done by transvaginal ultrasound، هيبقى البنتريشن اقوى، البنتريشن احسن، ده هيدينا ريزولوشن احسن وهنقدر نحدد الفيوز بتاعتنا بدقه. كمان الميد ساجيتال فيو بيبقى هو الموست امبورتنت فيو تو ديتكت البوستيريور فوسا مالفورميشن. بنقدر نعمل فيها اساسن كويس للبرين ستام تنتوريوم انجل والبرين ستام فيرمس انجل، وكمان الكرينيو كودال اند انتروبوستيريور فيرميان دايمترز اند فيرميان اريا. طيب علشان ما نلخبطش نفسنا ونعقد نفسنا هنبتدي ناخد نبذه عن كل حاجه من المالفورميشنز دي ببساطه، بحيث ان احنا نقدر نشخصها بسهوله ونعرف الامباكت بتاعها بوست نيتال. اول حاجه الداندي ووكر مالفورميشن بتبقى عندها كلاسيك تراياد اوف كومبليت اور بارشال اجينيسيس اوف سيربيلر فيرمز، وفي سيستيك دايلاتيشن اوف ذا فورث فنتريكل، وانلارجد posterior fossa، واهم تكه في الداندي ووكر مالفورميشن هي الابورد ديسبيسمنت اوف ذا تنتوريوم. الداندي ووكر مالفورميشن مشكلته ان معاه اسوشيتد CNS انوماليز وكمان اكسترا CNS انوماليز، وده بيبقى كومن قوي. واخر ستاديز كان معموله، عملوا ميتا اناليسيس سنه 2019، جمعوا كل الستاديز اللي عملت عن البوستيريور مالفورميشن بالذات الداندي ووكر، لقوا ان نسبه CNS انوماليز ممكن توصل اب تو 60% في الداندي ووكر مالفورميشن، خلاص، وعلى راسهم الفنتريكولوميجالي، في حين ان الاكسترا CNS structural anomalies كانت موجوده في حوالي 43% of the babies. وده يدلنا ان الداندي ووكر مالفورميشن مهم قوي ان هو يتشخص، لانه كان بي ذا كلو فور another malformations في البيبي. البريفالنس اوف chromosomal abnormalities in fetuses with Dandy Walker، خلاص، سواء associated مع CNS او extra CNS anomalies او لا، كانت حوالي 16%، وده برضو مهم جدا ان احنا نبقى عارفين. اهم كروموزومال ابنورماليتي كانت موجوده في الداندي ووكر مالفورميشن كانت هي الكروموزومال ديليشن. Isolated Dandy Walker is frequently associated with chromosomal aberrations, so karyotyping should be offered to fetuses suspected بالداندي ووكر malformation. ولو available عندنا ان احنا نعمل المايكرو اري اناليسيس، ده هيبقى افضل بكتير، لانه هيدي diagnosis احسن بكتير ومور accurate. طيب الماجورتي اوف ذا بيبيز اللي بورن with Dandy Walker malformation بيبقوا غالبا suspected في اول سنه من الولاده بsigns و symptoms of increased intracranial pressure. كمان الماكروكيفالي بيبقى most common manifestations affect around 90 to 100% of the fetuses during their first few months of life. زي ما حضراتكم عارفين الداندي ووكر الحقيقه يعني صعب اقول ان تخطئه العين، يعني اي حد هيشتغل سونار لازم هيلقطه ما دام يعني عارف البوستيريور فوسا مظبوط وشاف السيربيلم وعارف السيسترنا ماجنا، لان الدايلاتيشن بيبقى يعني بيوند ان انا تو بي ميزد مننا. هنا السيسترنا ماجنا بتبقى سيفيرلي دايليتد، والاهم في الموضوع هو الفيرمس اللي بيبقى فيه اجينيسيس او هايبوبلاستيك، خلاص. بس الاهم والتكه بتاعتنا اللي هتفرقها عن البليكس باوتش سيست هي الابورد اليفيشن او روتيشن بتاع السيربيلم. بنحس ان السيربيلم كانه اتنى او طلع لفوق شويه، يحصل له ابورد روتيشن. هي دي الحته الجزء المهم قوي اللي بيفرقه لي عن اذر مالفورميشنز في الداندي ووكر. تاني تشخيص بالنسبه لنا او حاجه كومن مالفورميشن في البوستيريور فوسا، ولو ان في ناس بتتحفظ على كلمه مالفورميشن، هي الميجا سيسترنا ماجنا. لان الميجا سيسترنا ماجنا والديفينيشن بتاعها هو ان انا اقيس الميجا سيسترنا ماجنا الاقيها اكتر من 10 ملم with normal verms. لقينا ان السيسترنا ماجنا زي ما هي قلنا مش congenital malformation، هي risk factor for malformation. تمام؟ لانها ممكن تبقى associated مع other CNS anomalies or extra CNS anomalies، بس الحقيقه ده بيبقى rare. يعني اغلب الحالات اللي موجوده في الليترشر بنلاقيها isolated ميجا سيسترنا ماجنا. لكن ده ما يمنعش ان انا لو لقيت اي سيسترنا ماجنا اكتر من 10 مللي ان انا هعمل حاجتين. اولا you inform the patient that this baby might have a chromosomal abnormality، خلاص، وان انا بعمل ديتيلد انومالي سكان لو كان البيبي ده اقل من 20 اسبوع بجيبها تعمل عند 20 ل 22 اسبوع ديتيلد انومالي سكان. الايزوليتد ميجا سيسترنا ماجنا usually have good prognosis، لان زي ما قلنا في ناس بتعتبرها انها ممكن تبقى نورمال فاريانت اصلا مش مالفورميشن. الفيرمين هايبوبليزيا ممكن تبقى associated مع other CNS anomalies برضو، وممكن تبقى isolated. الفيرمين هايبوبليزيا احنا زي ما قلنا حضراتكم ان السيربيلم مكون من 2 سيربيلر هيمسفيرز، تمام، وفي النص بيبقى الحاجه الايكوجينيك ستراكشر اللي بنسميها الفيرمز اوف ذا سيربيلم. السيربيلر هنا الفيرمين هايبوبليزيا او اجينيسيس، والاجينيسيس على فكره مختلف عن الهايبوبليزيا، والاثنين يعني مختلفين في التشخيص وفي البروجنوزس. الفيرمين هايبوبليزيا هنا لو ايزوليتد يوجوالي برضه بتبقى اوف جود بروجنوزس، والاذر انوماليز سواء السي ان اس او الاكسترا سي ان اس از نوت كومن. هنا عندنا السيربيلم 2 سيربيلر هيمسفيرز، وهنا الابسنت فيرمز بتاعنا او يعني هايبوبلاستيك، وهنا باينه ان في جزء كانه السيسترنا ماجنا دايليتد. Blake's pouch cyst is defined as the presence of upward displaced normal cerebellum worms with the normal appearance of the fastigium, tentorium and size of cisterna magna. The rate of CNS anomalies associated مع Blake's pouch cyst يعني هو مش قليل، يعني هو حوالي 11% في الميتا اناليسيس اللي اتعمل سنه 2019، والاكسترا CNS anomalies برضه arising up to 25%. اذا فهي كلو مهم زي ما قلنا للاذر malformations. من ضمن الكروموزومال abnormalities اللي بتبقى associated مع البليكس باوتش سيست هو الانوبلويدي، وعلى راسهم الترايزوميت 21. البليكس باوتش سيست for ultrasound evaluation في البوستيريور فوسا it is important to keep in mind that Blake's pouch is a normal embryological structure، يعني هي اصلا موجوده في الاستراكشر بتاعنا من الفيتال ديفلوبمنت، تمام، لكن المفروض ان بيحصل لها disappearance زي ما قلنا عند 18 من 16 ل 18 اسبوع. هنا هنلاحظ ادي السيربيلر هيمسفيرز الجزء ده، وهنا الفورث فنتريكل بتاعنا خلاص، وفي ابسنت فيرمز، وفي هنا كمان ايه البليكس باوتش سيست، وادي الوول الثين وول بتاعها اللي موجود. زي ما قلنا البليكس باوتش سيست المفروض انها نورمالي بتختفي من 16 ل 18 اسبوع، بس احيانا تفضل منها ريمننس تبان لي في السيسترنا ماجنا هنا كانها سيست موجوده في السيسترنا ماجنا، لكن زي ما حضراتكم شايفين السيربيلم از نورمال فيرمز، نورمال سيربيلر هيمسفيرز، والسيسترنا ماجنا هنا ممكن تبقى دايليتد او نوت، لكن البليكس باوتش سيست باينه بالثين وول بتاعها. في الرير انوماليز اللي قلنا ان هم موجودين لكن فيري رير انوماليز ويوجوالي ما بيبقاش معاهم دايليتد سيسترنا ماجنا، زي السيربيلر هايبوبليزيا او الرامبن كافل ساينابسيس والفيرميان اجينيسيس. السيربيلر هايبوبليزيا بتبقى تيبيكالي دايجنوزد في الثيرد ترايمستر، لانها ممكن ما يبانش السيربيلم لما يكون صغير او في هايبوبليزيا ما بيبانش في الايرلي فيرست والسكند ترايمستر، فللاسف ممكن يبان ليزر اون في الثيرد ترايمستر، وممكن يبقى للاسف ان هو ساعات يبقى على اللو نورمال بيرسنتايل كيرف، فالناس ما تاخدش بالها وتبقى ميزد ان هو نورمال سيربيلم. البونتو سيربيلر هايبربليزيا برضو بيبقى فيه سمول اور نورمال سيربيلم على اللو كيرف، بس هنا بيبقى فيه نقطه مهمه ان بيبقى معاه كمان فلات او ثين بونز. والحقيقه ان الدايجنوزس هنا بتاع البونتو سيربيلر هايبوبليزيا ما كانش الشخص غالبا بانترا يعني انتي بارتم او انترانيتال، غالبا بيتشخص بوست نيتال بالام ار اي. الرامبن كافل ساينابسيس دي بتبقى described كفيوجن of the two cerebellar hemispheres، وبقى معاها vermian hypoplasia او agenesis. الاكسيال ultrasound usually shows the cerebellum with the transverse diameter normal or below the 10th percentile for gestational age، وبيبقى شكله كاركترستيك قوي، بيدي ليه شكل triangular shape instead of the figure of 8 shape المعروف للسيربيلم. In the coronal plane, the foliation of the cerebellar hemispheres are continuous in the middle part of the cerebellum and no vermis is observed. ده منظر السيربيلم اهو بتاعنا. لو هتلاحظوا حضراتكم ان الايكوجينيك ستراكشر اللي هو كان عامل لنا الشكل التيبيكال فيجر اوف 8 اوف ذا سيربيلم اختفى وبقى عامل زي التراينجل ان شيب. اخر حاجه الفيرمين اجينيسيس اللي هي زي ما قلنا الفيرمس او الايكوجينيك ستراكشر اللي رابط ما بين التو سيربيلر هيمسفيرز بيبقى لو كومبليتلي ابسنت ده هنا بيبقى تشخيصه ان هو فيرمين اجينيسيس. والمهم في القصه دي زي ما قلنا اولا عشان نفرقه عن الفيرمين هايبوبليجيا اللي هي اوف جود بروجنوزس مش وحشه عن الفيرمين اجينيسيس اللي بيبقى معاه سندرومز كتيره اغلبها بتبقى يعني للاسف بتبقى فيها مشاكل بالذات بوست نيتال مع منتال ريتارديشن وابنورمال بيهيفير واتاكسيا وعلى راسهم الاشهر الجوبرت سندروم. والجوبرت سندروم من الحاجات الكاركترستيك ليه قوي مع الفيرمين اجينيسيس الكاركترستيك في الالترا ساوند والام ار اي هو المولر توث ساين بتاعتنا. شايفين باين هنا في الام ار اي مولر توث ساين دي دايجنوزز اوف فيرمين اجينيسيس الجوبرت سندروم. اليونيلاترال سيربيلر ليجنز يوجوالي السيربيلم هتبقى باينه قوي ان لو السيربيلم فيه اي ابنورماليتي سواء في ابليجيا او هايبوبليجيا في جزء من السيربيلم هتبان لما هيحصل ان في نورمال سيربيلر هيمسفير والفيرمس باين وانذر ايه سيربيلر هيمسفير از هايبوبلاستيك. دي يونيلاترال سيربيلر ليجن ويوجوالي بتبقى مش حاجه كونجنتال لا غالبا بتبقى حاجه نتيجه ديستراكشن انترا ناتال نتيجه انفاركشن او انفكشن او هيموريدج. اخر حاجه في البوستيريور فوسا مالفورميشن الاراكنويد سيست. الاراكنويد سيست مش خاصه بالبوستيريور فوسا لكن هي ممكن تيجي في الفرونتال لوب ممكن تيجي في البارايتال لكن لما بتيجي في البوستيريور فوسا ممكن تلخبطنا مع الاذر مالفورميشنز زي ما قلنا بليك سباوس سيست او الميجا سيسترنا ماجنا او غيره. لكن مثل الاراكنويد سيست ان هي بتبقى السي اس اف فلويد هنا مش واخد شكل ريجولر تمام فبتبقى شكلها كاركترستيك قوي. الاراكنويد سيست ميزتهم ان هم they don't communicate مع الفورث فنتريكل ولا السب اراكنويد سبيس ودي من النقط اوف ديفرنشيشن المهمه جدا بينها وبين الاذر posterior fossa malformations. زي ما حضراتكم شايفين هنلاحظ ان بس في جزء من السيستنا ماجنا مش كلها هي اللي دايليتد ممكن تبقى واخده جزء كبير من الفنتريكلز في الفورث فنتريكل هنا ممكن تبقى مأثره على السيربيلم خلاص. لحسن الحظ ان الاراكنويد سيست رغم ان هي ممكن زي ما احنا شايفين تكون مأثره او ضغطه على بعض البرين تيشوز لكن هي يوجوالي ات جوز اسيمتوماتيك لان بيحصل لها بعد كده ريجريشن تمام. لكن لو حصل سي اس اف obstruction it can lead to macrocephaly and developmental delay later on postnatal. طيب لو احنا يعني ما افتكرناش اي حاجه من اللكتشر دي اللي احنا يعني قلناها دلوقتي عايزه بس نبقى خارجين ببعض المعلومات المهمه اللي احنا عايزين نركز عليها في التيك هوم مسج. اول حاجه ان البوستيريور فوسا malformations are increasing in number دلوقتي وان هم must be diagnosed لتاثيرهم بوست نيتال المهم تمام. تاني حاجه ان احنا هنعملهم ترانس فاجينال في الفيرست ترايمستر we have to look at the posterior fossa for any marker للبوستيريور فوسا malformation. اشهر حاجه فيهم في البوستيريور فوسا malformation كلهم واهمهم واخطرهم هو الداندي ووكر malformation خلاص. بيبقى الالترا ساوند ايمجنج بتاعته مهمه بيبقى فيه ميجا سيسترنا ماجنا في ابسنت فورث فنتريكل تمام. الايزوليتد الداندي ووكر مالفورميشن هاز جود بروجنوزس بس يوجوالي لو هو مش ايزوليتد وده الاغلب في الحالات الداندي ووكر ان هو بيبقى معاه اذر سي ان اس انوماليز على راسهم الفنتريكولوميجالي او معاه اذر كروموزومال ابريشنز هنا البوست نيتال بروجنوزس مش هيبقى كويس. الايزوليتد ميجا سيسترنا ماجنا والبليك سباوتش تيست هاف لو ريسك اوف انوبلايدي ودي الجود نيوز اللي احنا ممكن ننقلها للعيان خلاص. وكمان الاحسن ان هم عندهم جود بروجنوزز زي ما قلنا لان هم they are not malformations in their own they are risk factor for malformations فهم كلو ليا ان انا ابص على البيبي كويس لكن هم في حد ذاتهم مش حاجه خطيره. النون visualization of the choroid plexus of fourth ventricle in the first trimester is a very strong marker of the posterior fossa anomalies and chromosomal defects. طيب في حد عنده اي اسئله في المحاضره؟ اتفضل. هي نورمالي المفروض تختفي من 16 ل 18 اسبوع. لو حصل انها يعني persisted هنشوفها persisted كامله ولا ممكن يبقى فيها remnants بس. وحسب البرسيستنس ده هنيفاليويت البيبي ده كمان هل في انذر سي ان اس انوماليز معاها او في اذر اكسترا سي ان اس انوماليز ولا لا. وهو ده اللي هيفرق معانا في الدايجنوز والبروجنوزس. تمام. تمام كويس. يبقى هي غالبا ميس دايجنوز على انها بلاكس باوتش سيست، في حين انها كانت داندي ووكر من الاول. مش لازم هيبقى في كل الحالات من فينتريكول ميجلي، الفينتريكول ميجلي موجود احيانا في اغلب الحالات، هو يعني نمبر 1 في السي ان اس انوماليز اللي ممكن تبقى موجوده مع الداندي ووكر. لكن هو النقطه بقى، هل هم كان الفورث فينتريكل اصلا موجود ودايليتد، وهل الفيرمس كان موجود ولا لا؟ لان المفروض الداندي ووكر التفرقه بينه وبين البليكس باوتشز الاساسيه هو الابسنس اوف فيرمس او الهايبوبلاستيك سيرفيلر فيرمس. تمام؟ اوكي شكرا دكتور. طيب لو ما ركزناش او didn't memorize او didn't understand اي حاجه في المحاضره النهارده it is perfectly normal. وماي جيفت تو يو هي الدايجرام الاخير ده اللي ممكن يسهل لنا الدنيا شويه في المحاضره دي. خلاص الدايجرام ده كان معمول في واحده من الستاديز الايطاليان اللي اتعملت على البوستيريور فوسا مالفورميشن، وعجبني الحقيقه ان هو مسهل الامور قوي. اول حاجه انا دلوقتي سسبكتد في posterior fossa malformation عن طريق ان انا شفت في dilated cisterna magna او الفورث ventricle dilated او الفيرمس فيه مشكله، يبقى انا شاكك ان في حاجه في الposterior fossa malformation. اول حاجه هسال نفسي سؤال، هي السيسترنا ماجنا dilated ولا نورمال؟ يعني اقل من 10 مللي ولا اكتر من 10 مللي؟ لو هي نورمال سيسترنا ماجنا هفكر في الحاجات النون سيستيك اللي هم cerebellar hypoplasia، rhomboencephalous synapses والفيرمن اجينسيس. لو السيسترنا ماجنا دايليتد اكتر من 10 مللي، شوف السيسترنا ماجنا دلوقتي كوميونيكيتنج مع الفورث فنتريكل ولا مش كوميونيكيتنج. لو كوميونيكيتنج يبقى احنا كده بنتكلم في ان في داندي ووكر ايه مالفورميشن كومبلكس. خلاص؟ طيب لو مش دايليتد، لو مش كوميونيكيتد انا اسفه، يبقى دي جاست اميجا سيسترنا ماجنا. طيب الدايليتد او السيسترنا ماجنا ومعاها كوميونيكيشن مع الفورث فنتريكل، يبقى زي ما قلنا ده هيبقى غالبا داندي ووكر مالفورميشن او فاريانت. يبقى ساعتها هعمل استيميشن للفيستيجيوم والفيرمس والتنتوريوم واشوفهم نورمال ولا اب نورمال. اسهلهم كلهم اللي هيطلع فيهم نورمال فيهم الثلاثه، الفيستيجيوم والفيرمس والتنتوريوم، دي غالبا هتبقى بليكس باوتش سيست. لو حصل ان التنتوريوم بس النورمال لكن الفيستيجيوم والفيرمس ار اب نورمال، يبقى دي الفيرمين هايبوبليجيا. خلاص، ومن اسمها الفيرمس اب نورمال يبقى كمان عندي ايه؟ فيرمين هايبوبليجيا. تمام؟ لو طلعوا كلهم اب نورمال وفي عندي الاليفيتد تنتوريوم او اللي هو الابورد روتيشن اوف ذا سيربيلم، ده هيبقى الداندي ووكر مالفورميشن. وزي ما قلنا ده اخطر واحد فيهم لان هو ده اللي بيبقى اسوشيتد اكتر مع السي ان اس انوماليز والاكسترا سي ان اس انوماليز والكروموزومال ابريشنز، فده اللي ممكن يزعجني ويعمل لي بوست نيتال بروبلمز. تمام؟ ثانك يو.